Good afternoon, everyone. Welcome to our endocrine grand rounds. Today, we have our own faculty, Malika Rawal, who will present to us. Dr. Rawal came to us after finishing a residency in Pittsburgh. Um, she came here in 2019 and completed her fellowship training in 2021. She joined our faculty in 2021. She has been here for the last 4 years, starting through going through all the COVID and other adventures with us. She has been an outstanding clinician and educator. She has done some very good work in developing our clinical programs, particularly related to transgender medicine, and also in helping our fellows and residents train in endocrinology. Today, she'll be talking about growth hormone deficiency in adults. Um, it would be a nice thing if we did have last month's pediatric endocrinology lecture, which was actually supposed to be on growth hormone deficiency, but we had to cancel it because of weather. So we hope we'll get that back on track maybe next month or whenever. So, Malika. Mhm.
Hey, thank you, Dr. Mokshigandam. And it's kind of serendipitous. I happened to choose this topic, but in deciding what to talk about today, um, I admit to selfish motives because I don't have many opportunities to do growth hormone therapy in adult patients. And I know in the pediatric world and in our amazing pediatric colleagues, they probably are much more familiar with this. But something I thought we could review as adult endocrinology today in particular, kind of refresh our knowledge about it. So thank you again, Dr. Mokshigandam, for that introduction. So I have no conflicts of interest to disclose. Today, there are a couple of objectives. So just the usual, starting with the physiologic roles of growth hormone and talking about it in general, to talk about the causes and consequences that might lead to growth hormone deficiency, to talk about testing strategies to diagnose growth hormone deficiency in adults, to recognize treatments and screenings for patients that have adult growth hormone deficiency, and to talk about the benefits and risks of actually treating with recombinant human growth hormone in our adult patients. So always a good place to start is with the history. So where did this whole idea of growth hormone come from? When did we first recognize it? So it started in the 1880s when a French neurologist, Pierre Marie, talked about a condition called acromegaly, which we're very familiar with now, caused by abnormal growth of the limbs, hands, feet, face, and enlargement of the structures. And then, Harvey Cushing, of course, in the 1900s talked about the hormone of growth, specifically again about acromegaly and growth hormone excess. In 1921, two researchers talked about the growth promoting effects of administering cow pituitary gland into rats and what happened to them. So they ground up the hypothesis and gave it to the rats and noticed that they had growth of body structures and different metabolic consequences. And then in the 1930s, two further scientists kind of discovered that concept that growth hormone is actually species specific. And what they noticed is that rhesus monkeys responded better when given cadaveric rhesus pituitary rather than other animals or other species pituitary glands. And the reactions were more species specific. So that was the first idea of that. And then in 1955, Dr. Howley discovered human growth hormone, specifically implementing his own method for isolating it from human cadavers and purifying it to administer and study. And in 1971, he, outlined the structure and started synthesizing human growth hormone. He's also credited with discovery of actually 8 of 9 of our anterior pituitary hormones, and also beta endorphin, which is a major player in the pain pathway. So very important in neurophysiology in the endocrine world. Unfortunately, as many may know, there was some controversy related to growth hormone that still continues now, and a link between receiving growth hormone from both cadavers and synthesized human growth hormone and a development with Creutzfeldt-Jakob disease. And so this has been ongoing since the 1970s, and even there are some cases continuing now that they're finding children that were treated in the past are now having continued neurological findings into adulthood, including early cognitive decline associated with Creutzfeldt-Jakob disease compared to other patients that have other forms of dementia, and then a link between Alzheimer's, Creutzfeldt-Jakob disease, and human growth hormone. So these are, again, rare, but definitely things that kind of give us pause or gave us pause about using growth hormone and how to better do this and make sure this doesn't happen. It was believed that initially the cases were due to just contaminated cadavers and cadaveric specimens. So, recombinant human growth hormone has not necessarily been associated with this same risk. So, short stature is one feature of human growth hormone deficiency, but short stature can apply to 2% of people worldwide. Patients that have true growth hormone deficiency often have a height that's more than 2 standard deviations below the mean height for their age, and definitely below their expected mid-parental height. In patients with growth hormone deficiency that are not treated, the average adult height is about 56 inches in men and about 51 inches in women. Growth hormone deficiency has been estimated to be about 50,000 adults worldwide, 6,000 new cases per year in the US, and about a fifth of those represent patients that were diagnosed with congenital growth hormone deficiency and transitioned to adult care. So growth hormone, also known as somatotropin, is produced by the somatotrope cells in the anterior pituitary gland. It's a 191 amino acid polypeptide hormone. And interestingly, it has 22% homology to prolactin, another anterior pituitary hormone. A lot of times the cells that produce these hormones are referred to collectively as somatolactotrophs. So they do have some similar structures, and there are conditions where a functional pituitary neuroendocrine tumor can be producing both substances. So similarly, we'll keep that in mind when we go forward in our lecture and talk about growth hormone deficiency. It has direct actions through its own receptor at the growth plate itself and in other parts of the body, but most growth hormone actions in the body are mediated through IGF-1, insulin-like growth factor 1, and then also to a more minor role by IGF-2. IGF-1 is synthesized in the liver and in many other tissues in the body, and it usually travels bound to certain binding proteins labeled 1 through 6, and those IGF and IGF binding proteins are better surrogate markers for measurement of growth hormone activity in a body and for diagnosing deficiency, and we'll get more to that a little bit later. So growth hormone is under the regulation of a couple hormones that are both inhibitory and stimulatory. So stimulation of growth hormone release from the anterior pituitary is under control of growth hormone releasing hormone from the hypothalamus, and is inhibited by the release of somatostatin from the hypothalamus. Once growth hormone is secreted, it goes to the liver to stimulate production of IGF-1, as we talked about. It also has direct actions on adipose tissue, causing release of free fatty acids, lipolysis, and also has downstream gluconeogenesis and other effects on glucose levels and metabolism. Free fatty acids and IGF-1 will feed back to the pituitary and hypothalamus to prevent further release of growth hormone when levels are adequate. And then some other stimulators of growth hormone secretion that are important to remember, both at the pituitary and hypothalamic level, are ghrelin from the stomach, so hunger and starvation, stress, and this could be physiologic, emotional, amino acids, and hypoglycemia. This is a typical kind of pattern of secretion of growth hormone throughout the day. And it features also in here the spike at the beginning, which shows the effect of strenuous exercise on growth hormone release. And so that's not really a timed phenomenon, but just an example. So growth hormone, has various peaks throughout the day. Most notably during the first few hours of sleep. So we can see a large spike there, kind of leading up until midnight. And this kind of helps us to figure out what the levels should be. So what are the consequences if you don't have enough growth hormone? Again, the consequences will be very different in pediatric patients versus adult patients. In pediatric patients, growth hormone deficiency has a number of effects, such as decreased intellect, decreased maximal skeletal height, changes in body composition, and can be associated with certain syndromes that have other congenital findings and midline findings in particular, like changes in the palate, changes in facial features, speech pattern issues, and changes in genitalia, etc. In adults, these are some of the most common findings with growth hormone deficiency. So kind of a syndrome of impaired metabolic and skeletal health. So you'll see increased fat mass, especially central and visceral adiposity, decreased lean body mass and musculature, and decreased strength overall. These patients tend to have reduced exercise capacity and decreased oxygen carrying capacity, and decreased bone mineral density compared to their peers. They have increased risk of fracture accordingly. Their lipid profile tends to be more atherogenic with higher LDL and lower HDL. They can have skin changes as well. And then importantly, something we may overlook are the psychosocial issues and impaired quality of life. So patients with growth hormone deficiency sometimes describe attention deficit disorders, social isolation, difficulty with sleep, difficulty meeting new people and making friends and interacting, depression, and numerous other neuropsychiatric complaints. So specifically, some studies have shown when it comes to increased fat mass that patients with growth hormone deficiency can have 7% higher body fat percentage and an increased waist to hip ratio, which we know is associated with the metabolic syndrome. As far as cardiac health and atherogenicity, they can have increased carotid intima-medial wall thickness, reduced left ventricular ejection fraction, decreased cardiac output, as we said, and up to 20 to 25% reduction in exercise capacity. When it comes to osteoporosis, they have decreases in both their cortical and trabecular bone mineral density scores that can be up to 2.8 to 1.8 standard deviations below their age and sex matched controls, which is pretty significant. And then, as we talked about, low HDL, increased triglyceride, and increased LDL as well are features of their typical lipid profile in an untreated patient with growth hormone deficiency. And then, of course, we can't forget that growth hormone deficiency in adults oftentimes occurs alongside other pituitary hormone deficiencies, depending on the cause of their growth hormone deficiency. So the other symptoms and signs of those comorbid hormone deficiencies will also impact their overall quality of life and health status. This is the developed adult growth hormone deficiency quality of life assessment. And so this is something that was new to me, and not a tool I've used before, but has this questionnaire of numerous items, and basically things as if I have struggled to finish jobs, I lack confidence, takes a lot of effort for me to do simple tasks, speaking to their attention, ability to concentrate on a task. I find it difficult to plan ahead. I'm easily irritated. And it's suggested that patients do this screening if you're concerned or you have diagnosed growth hormone deficiency. And the National Institute for Health and Care Excellence in the UK has recommended that patients might be appropriate for growth hormone deficiency replacement if they meet these three criteria, which are that they have severe growth hormone deficiency, and we'll talk about how that's diagnosed. If they're already getting full and adequate replacement for any comorbid pituitary hormone deficiencies, and if they score at least 11 points on this assessment. So each item is 1 point. Okay, so some causes of growth hormone deficiency for us to keep in mind in our adult patients. Overall, broadly, there can be a number of congenital causes, and these will be seen more in our pediatric colleagues' practice in diagnosing those patients, but they could be genetic in nature, a defect or mutation in the growth hormone releasing hormone receptor or growth hormone 1 receptor itself. There could be mutations associated with development of the pituitary gland, such as prop mutations, poof mutations, and those that we're very familiar with from our board exam studies. There could be structural brain malformations, like agenesis of the corpus callosum, where they have a deficiency in communication between the two sides of the cerebral hemispheres, a Rathke's cleft cyst, pituitary stalk interruption syndrome, holoprosencephaly, or septo-optic dysplasia. So just to focus on two syndromes that I think might be less familiar. One is pituitary stalk interruption syndrome. So this is a triad that is characterized by a thin or interrupted pituitary infundibulum, misplaced or ectopic posterior pituitary tissue, and a smaller absent anterior pituitary, and they are all characterized by a permanent growth hormone deficit. These patients can present soon after birth with neonatal hypoglycemia, jaundice, congenital abnormalities such as micropenis, cryptorchidism, short stature, seizures, hypotension, and intellectual delay. And then septo-optic dysplasia is a syndrome that's also known as de Morsier syndrome. And basically, it is a congenital disorder where there's underdevelopment of the optic nerve and absence of the septum pellucidum and pituitary gland dysfunction. So these patients present with numerous issues with their voluntary and involuntary eye movements, with seizures and hormonal problems and low muscle tone. Acquired causes of growth hormone deficiency are numerous. About 2/3 of adult cases of growth hormone deficiency are related to the diagnosis of a pituitary adenoma and treatment of such. It can also be due to other midline tumors like a craniopharyngioma, a germinoma, optic nerve glioma, and also due to ischemia or apoplexy of the pituitary region or pituitary tissue. There's been more attention in the past decade or so to the role of traumatic brain injury and how that can cause adult growth hormone deficiency. Typically, these cases tend to be diagnosed within 1 year of trauma, but there have been case reports citing trauma as far back as 40 years prior. And then, of course, any other process that could infect the cellular region and pituitary region, such as irradiation for cancers, infections, infiltrative diseases such as histiocytosis, and secondary things such as very poorly controlled hypothyroidism, type 2 diabetes, and certain medications and substances. To diagnose growth hormone deficiency, we have to first keep in mind that growth hormone levels themselves, as we saw at the beginning, are very difficult to measure in an accurate way. Firstly, growth hormone has a very short half-life of just 20 minutes, and it's released in different bursts. There are numerous factors that lead to increased secretion of growth hormone in certain patterns. So we typically tend to measure IGF-1. And that's a good place to start. Although in patients with adult growth hormone deficiency, up to 60% in one study had normal IGF-1 levels. So may not always be the best indicator. For example, if there's a patient in clinic that happens to have pituitary hormone deficiencies, or they've had a pituitary resection, and you measure an IGF level, just because it's normal doesn't mean they don't have growth hormone deficiency. So something to keep in mind. There's also variants that we have to keep in mind, such as gender-specific variants. So female patients with growth hormone deficiency tend to have lower IGF-1 levels than their male counterparts. And there's also a normal age-related decline in IGF-1 levels to keep in mind. So IGF-1 is commonly measured along with a Z-score, with -2 to 2 being the normal range and making you feel more comfortable about the level and whether it's falling in that normal range or not. One study suggested that using a total IGF-1 threshold of 84, less than 84, in patients that have 3 or more other pituitary hormone deficiencies can provide a 95% accurate diagnosis for diagnosing growth hormone deficiency in adults. So, I found that kind of interesting. So that might be a case where we may not have to do provocative testing. However, most of the time we do, and this is for both adults and children. As with everything in endocrine, if we think something's low, we try to stimulate it and see if it truly is low. And so it's recommended that we focus our testing on people that we think have a very high pretest probability. So for example, if they have other pituitary hormone deficiencies, or if they had structural disease or bleeding of the hypothalamic or pituitary regions, or a history of surgery, head trauma in that area, those are adult patients that we should definitely consider testing. Important to keep in mind also that our pediatric patients that are transitioning to adult care should be rechallenged and retested for growth hormone deficiency to see if it should continue as an adult. That being said, most guidelines that I encountered did discuss that adolescent patients that are being treated for congenital growth hormone deficiency should not stop at the time that they finish puberty necessarily, but continue into their earlier mid-20s, because oftentimes stopping prematurely can decrease their height velocity and lead to other quality of life issues and metabolic issues. So it's not like a fixed cutoff like 18 and you're done. So something to keep in mind. All right, the gold standard is the insulin tolerance test. So this is done by measuring growth hormone levels at numerous time points, 0 to 180 minutes. Some studies actually say up to 240 minutes at about 30 to 90-minute intervals. And after your baseline measurement, you're going to give them 0.15 units per kg of IV insulin. Sorry for that typo. And your goal is to make them have hypoglycemia less than 40, and then measure the growth hormone levels. A growth hormone level that remains less than 5 throughout this is very highly suggestive of growth hormone deficiency, because as we saw earlier, hypoglycemia is a very potent stimulator, actually the most potent stimulator of growth hormone secretion, more so than a protein load, more so than exercise. So, clearly we can see some pitfalls in this or some difficulties to this testing, even though it is the gold standard, namely that there are numerous contraindications and patients that we wouldn't want to cause hypoglycemia in, such as patients with coronary artery disease or a history of prior stroke or cerebrovascular disease, our elderly patients, and those who have had seizures before. And then also, doing this test can sometimes precipitate adrenal insufficiency. So it's recommended that an 8 a.m. cortisol be checked first before this procedure, and to not proceed with testing if their cortisol is less than 3.6 micrograms per deciliter. Another test that's been developed to diagnose growth hormone deficiency is the glucagon stimulation test. This is a test that requires fasting up until the test and measurement of growth hormone, glucose, and insulin at 30-minute intervals for up to 3 hours. The provocation being that the patients receive 1 milligram or 1.5 milligrams if they're particularly obese of IM or sub-Q glucagon. And the goal is that your growth hormone should stimulate above 3 nanograms per milliliter. And using this cutoff, it has been described to have a sensitivity of up to 97 to 100% for diagnosing growth hormone deficiency, and a specificity varying from 88 to 100% in different studies. Side effects of glucagon include nausea, vomiting, dizziness, and hypertension. So it's recommended in patients with uncontrolled hypertension or pheochromocytoma not to do this particular test. Another test is to use growth hormone secretagogues or ghrelin secretagogues, and the most common being massimorelin. And so this is actually interesting because it's not a parenteral test. It's an oral solution that they're going to drink, and you're going to measure your growth hormone at 15-minute intervals for 90 minutes. And there are different cutoffs that I saw described. Originally, the cutoff was 2.7, but it was found that even a cutoff of 5.1 nanograms per milliliter can have up to a 92% sensitivity, a 96% specificity, and 82% accuracy for diagnosing growth hormone deficiency. There are very minimal side effects to this test, and the benefit being, one, it's not parenteral. Two, unlike the insulin tolerance test, you don't have to be in a supervised setting in the sense that you're not afraid of hypoglycemia and the consequences of such. And the response of growth hormone to these secretagogues is very rapid. So the peak growth hormone response occurs within 60 minutes. So it's not a very prolonged test, as opposed to others that go for, three or more hours long. One test I didn't talk about, but it is summarized here on this summary slide, is the growth hormone releasing hormone and arginine test, only because growth hormone releasing hormone is not commercially available any longer in the United States. So not something that we commonly do. So this is just kind of a summary slide, and we've talked about most of the things here. All right. So now that we've kind of had a background, we'll talk about why we might consider giving treatment and what benefits there could be. Firstly, on body composition. So as we talked about, growth hormone deficiency can cause a decrease in lean body mass and an increase in fat mass. And this overall is going to predispose to metabolic syndrome and increased ASCVD risk. So patients that were treated with growth hormone replacement in several studies have shown reduced adiposity, but particularly in this study, they found a 9% reduction in adiposity in patients treated with growth hormone that had growth hormone deficiency versus those that had growth hormone deficiency and were given placebo, who actually had a 4.2% increase in their adipose percentage. And then lean body mass was also studied by this other group, and basically they showed that lean body mass did improve with growth hormone therapy, but less so than the degree of improvement in adiposity. However, the increase in lean body mass was a more sustained finding. So even when patients discontinued use of growth hormone replacement, they continued for up to 10 years to have improvements in their lean body mass. There's also benefit on your lipid profile. So growth hormone replacement therapy has been shown to reduce total and LDL cholesterol, improve your HDL, and this effect seems to be more pronounced and more synergistic when used with HMG-CoA reductase inhibitors. And then also several studies have shown that there's a decrease in the carotid intima media thickness as well once you have treatment with growth hormone deficiency, growth hormone replacement. There's also improvement in cardiac function, which is a major contributor towards mortality in these patients. They have increased exercise capacity and increased cardiac function in several aspects, including their stroke volume, reduction in left ventricular mass, and improvement in left ventricular end diastolic pressure. Bone health also improves with growth hormone therapy. Studies have cited up to 4 to 10% increase in bone mineral density, and that improvement seems to be more pronounced if they started with very severe low bone mineral density or if they were men. Men tended to have a better response to improving their bone mineral density than women that were treated with growth hormone. And these changes are also biphasic. So initially, when patients receive growth hormone therapy, there is actually just a period of bone resorption for up to 6 months, followed by an increase in bone mass thereafter. And this also was sustained after discontinuing therapy. And then quality of life. So quality of life did improve subjectively with growth hormone replacement therapy. And this also, even after stopping therapy, their quality of life improvement seemed to be sustained for many years. All right, so how do we dose this and what are our goals? So there are a number of approved conditions for receiving growth hormone replacement therapy. Things I won't talk about today, but are exciting and newsworthy are the use of growth hormone in aging clinics and in athletic events. But these are the ones for which it's approved. So it started initially as approval for childhood growth hormone deficiency, followed a little over a decade later for approval for adult growth hormone deficiency. But you can see there are numerous non-growth hormone deficient states for which this is FDA approved, including Prader-Willi syndrome, HIV and AIDS-related wasting syndrome, idiopathic short stature, Noonan syndrome, small bowel syndrome, so a number of congenital syndromes and others. There are multiple formulations of growth hormone available. These are the list of things that are available in the States. So somatotropin is the generic name for a recombinant human growth hormone. It's a daily injection in most cases and has numerous brand names and companies that provide this. Tesamorelin, also known as Agrifta, is a subcutaneous daily powder injection that can be used as well, which is a ghrelin and GH secretagogue. Somatotropin is a sub-Q weekly injection, which is more for congenital growth hormone deficiency at this point, hasn't been approved yet for adult growth hormone deficiency. And then Skytrofta or Alonopeg somatotropin TCGD is also a subcutaneous weekly injection for congenital growth hormone deficiency. And then I have my little sad face by compounded semorelin, which is, the compounded version of growth hormone, just like, everything these days. And there's always a compounded version. This is sold by a number of anti-aging clinics, so something to look out for in your patients. Side effects of growth hormone replacement therapy have been described, and there are multiple. It's important to note that subsequent studies have shown that a lot of these side effects are more to do with supraphysiologic replacement of growth hormone rather than just replacing a deficit in patients that are already deficient. And so that's why a lot of these side effects overlap with what we'd expect to see in patients with acromegaly. So that includes arthralgias, myalgias, paresthesias, including carpal tunnel syndrome, sleep apnea due to growth of soft tissue, swelling, fluid retention. There also have been a couple case reports of non-diabetic patients developing macular edema. There have been 2 of these reported in literature. And then some noise about, insulin resistance and type 2 diabetes. So initially, studies that followed congenital growth hormone deficiency patients felt that these patients developed more type 2 diabetes and insulin resistance. But in congenital growth hormone deficiency, the dosing is weight-based. And we'll, soon talk about how in adult growth hormone deficiency, dosing may start as weight-based, but is basically titrated to clinical benefit and IGF-1 levels rather than their weight. And then further studies, a big study in 2002 by Banktis-Sun and colleagues did not show that the adult patients that started growth hormone deficiency treatment developed type 2 diabetes or resistance, more insulin resistance more than patients that were not treated. And then also there's been some concern about whether growth hormone replacement may increase risk for malignancy, either de novo or secondary. And basically, most studies have not shown any clear link between using growth hormone replacement for patients that are truly deficient and increased risk for malignancy. And that's the important kind of phrase there is, we are replacing what's deficient rather than doing super physiologic dosing. So something to counsel patients on. These are adapted from the AACE recommendations for growth hormone dosing. And so it's recommended that in certain patients, you can start a little higher when they're weight-based dose. So if they're very young and they're transitioning from pediatric treatment, you can start at a dose of 0.4 to 0.5 milligrams per day. And keep in mind that as we get older and our IGF-1 and growth hormone levels should be declining, our calculation is going to decrease. And so if they're kind of, 30 to 60 years, 0.2 to 0.3 milligrams per day might be a good start, and milligrams per day. And then if they're elderly, then using very lower doses like 0.1 to 0.2 milligrams per day. And then in patients that have diabetes and you may be worried about insulin resistance, you definitely want to go on the lower end as well. And then titrate the dose again based on clinical response, their IGF-1 levels, their side effects, and their metabolic indices. So another thing to keep in mind is estrogen status. Patients that are on oral estrogen can have increased growth hormone replacement needs. So you may have to dose them a little bit higher. And this effect does not apply to parenteral or transdermal estrogen, only oral. It's recommended that the dose be adjusted every 6 to 8 weeks until your IGF-1 levels are consistently in the upper 50% of normal range, and they have minimal side effects and good clinical response. After they reach a steady state, you can continue to monitor them every 6 months, keeping in mind their metabolic health. So measuring their A1C, their glucose levels, and their lipids, LFTs as well. And again, after any dose increase, if you tend to increase their dose a little sooner than 6 months. And then bone mineral density should be assessed at baseline and at least every 2 years. Of course, if they have any osteopenia or osteoporosis, you're going to monitor them according to guidelines for that condition and sooner than every 2 years. And then do assessments of their quality of life regularly. and make sure that they're having improvements in their functioning in daily life. All right, and I think that's actually all I have. So I'm going to give you guys some time back this afternoon, but I welcome any questions that you guys have at this point.
One is something would be very welcome for a lot of patients.
Yeah.
So my question is, we often struggle, the clear indications are continuing from childhood to adulthood, the congenital, the multiple axis abnormalities, like they have three, naturally they could. But the unclear ones, which, like you mentioned earlier, apart from the anti-aging, is patients coming with de novo and stimulation testing. And of course, we have Massimorgan available now. I've done one or two, but not too many. So the isolated adult growth hormone deficiency, as far as I know, Endo Society has not approved that as an entity. Is that the case? Because with high BMI, many times, just like total T and SHBG, you have the same issue here also with the IGF-1 being lower.
Yeah. I think, from what I saw, there definitely are cases where the stimulation test may prove isolated growth hormone deficiency and it's from other conditions. I think that basically the main thing I learned from this is just because they have it in a moment and they may at that point need some growth hormone replacement doesn't mean you don't continue to challenge and see when they can wean off as adults. The same way you don't assume that just because they had a need for growth hormone replacement as a pediatric patient that as an adult they still need it. So I think in that case, the the use of growth hormone replacement might be approved if you have stimulation tests that prove deficiency according to the cutoffs. But I think I would, at least annually kind of reassess their need to continue it and control the underlying condition as well.
More. So it's for the HIV associated, like, or
Wasting syndrome, yeah. Yeah.
The bone density, that's a good point. I know in the children, there's some concern with skiffy or something like that. So I know when I was in pediatric in the fellowship in the rotation, they used to talk about it. So in adults, are they concerned that it can lower bone density? Because there's also some speculation that you could use it to improve bone density at some point.
If growth hormone replacement lowers bone density, all the studies.
I saw the comment about the DEXA.
Yeah, all the studies have shown actually the opposite, that your bone scores, especially in your vertebra, but also in your appendicular skeleton, improve with growth hormone replacement. Yeah.
So you're allowed to, even though they're younger than the age group for the adult, like the US Preventive Task Force says only you have over a certain age, but if they're on growth hormone, we are able to DEXA them earlier.
That I can't answer because I've never had to. I've never. Yeah, the question is if insurance will allow us to do a DEXA every 2 years in patients that are growth hormone deficient but younger than the typical screening ages. I think again, it's a case by case and insurance by insurance thing, but these are what our recommendations are as far as screening and monitoring. Yeah. On the chat.
One other question I had was, is there information looking at post-acromegaly treatment, long-term growth hormone deficient patients who have symptoms and anything about treatment?
Oh,
Like giving testosterone to patients years after prostate cancer?
Yeah, so the question is there any information about how to treat patients that were treated for acromegaly and have symptoms of growth hormone deficiency after the fact? That I didn't specifically look into, but I can, and I'll let you know. Yeah. I would think, correct me if I'm wrong, but I think acromegaly can have a pretty high recurrence rate. So I wouldn't think.
Years later,
Yeah.
when they
I see.
found it in the past.
I'll definitely look for it and I'll send it out. Yeah. So Thank you, Radwan. Thank you, Bushra. So in view of circulating daily rhythm, does it impact on interpreting any of the SIM tests? Great question. I don't think as far as IGF-1 levels, it would change it as much. But, and again, I think no matter the time of day, certain stimulators of growth hormone release will always have that effect. And that's why I think part of the reason why checking your random level is so difficult to interpret. So as far as I know, there's no specific effect of it altered circadian rhythm on when you would do a stimulatory test. But I'll ask my senior colleagues what they think. Do you think? Oh, yeah. The good answer from Dr. Milk is always do it in the morning. I think that's true of most endocrine stim tests. Yeah. Yeah.
Yeah, so the Hormone was a welcome addition. In fact, we were going to do a study looking at mild traumatic brain injury in veterans who had TBI, and we were looking for growth hormone deficiency. We were one of the sites, but it didn't happen because we didn't have enough rehab support at VA. But so the insulin tolerance test, yeah, I know I had that question. You had mentioned about cortisol 3.6. It seemed like a really low number.
It is low. That's kind of like so the question is, why is the cortisol cutoff for doing an insulin tolerance test so low at 3.6? It is low, but that's kind of like the do not proceed level. I think if it's kind of borderline, you can kind of use your own clinical judgment, but that's like an absolute no, don't do that. Yeah, I hope to never have to do it. Yeah, 40 doesn't seem like a good time. Yeah. 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 Good. Yeah, I think traumatic brain injury is a population that we see fairly often in our consult service and not something that before I made the connection to growth hormone deficiency. So definitely preparing for this has made me think about that a little bit more. But
Yeah.
yeah.
Yeah. The study was going on, multi-center VA cooperative study, looking at mild traumatic brain injury without structural damage and growth hormone replacement. And Massimilian was working with. But I still have boxes of that sitting in my office.
Oh, wow. Yeah, the one time I've ever prescribed growth hormone therapy to an adult patient, they had congenital growth hormone deficiency, and I did a stimulatory test, and we confirmed it. And because their BMI was greater than 40, we had a really hard time getting pharmacy to approve, even at lower doses. But like eventually, I said like this is going to improve his BMI and overall, metabolic risk. So pediatric. Yeah.
You have those syndrome.
Yeah.
I remember 2 others. Certainly, it's a more peds thing than adults. And as soon as they become adults, I have to cut back their doses, just like you mentioned, the few that I have. So.
Great. Yeah. Any other questions? All right. Well, I hope everyone enjoys the warm weather. Thanks.